Welcome to our Mary Greeley Primetime Alive presentation, Women's Pelvic Health. I'm Vicki Newell, and I manage the Primetime Alive program here at Mary Greeley Medical Center. As a reminder, if you would like more information about the Primetime Alive program, you can go to mgmc.org/PTA. While you're there, you can also see upcoming programs and sign up. You can also see past recordings of our program. So there's lots of great information there. Our presenter today is Katie Albrecht. Katie received her undergrad degree and her master's in physical therapy from the University of Iowa. Katie has been working in the area of pelvic health for more than 20 years. She has spent 10 years at the University Hospital in Iowa City, and now has been here at Mary Greeley Medical Center for 10 years. Please welcome Katie.
Thank you, Vicki, for such a nice introduction. While I'm just adjusting my screen here, I want you all to just, because my camera is not on, I want you all to just picture me not just having a good hair day, but like full-on supermodel, which if any of you have actually met me, I'm like 5 feet tall. So that's saying something. So yeah, thank you guys for inviting me to come talk with you about women's pelvic health today. Like Vicki said, I started out my career at the University of Iowa in Iowa City. Did my undergrad and my graduate work there, and then worked at that hospital for 10 years. And then I met a boy who lived in Ames. And so I moved here to Ames and have been working at Mary Greeley since 2011, I believe. So I don't want you to hold it against me that I spent so much time in Iowa City. We did just get season football tickets for the Cyclones, so I'm slowly switching over to the dark side. So today we're going to talk about women's pelvic health, and I think we should just start with what that even means. To me, it's a lot. I mean, there is a lot going on in a woman's body between her belly button and her mid-thigh, which is what I consider to be, that's my area of expertise. And this is something that I could talk about for days and days. And so it is sometimes hard for me to squish it into a shorter presentation. So what I'm doing today, the items on your screen that you see that are highlighted in red, those are the things that we're going to talk about today. I just wanted to include a larger list so that you could see really all of the things that can contribute to pelvic health. So as we look through this list, the first thing we're going to talk about is incontinence, which is just another word for urine leakage. And we'll go into the different types of incontinence and what we can do as a physical therapist to help you manage symptoms of incontinence. We're going to talk a little bit about prolapse, which is basically a bulging of the vagina. We'll talk about bowel dysfunction. That's a whole other lecture in and of itself, but we'll go through the basics of some things that have to do with bowel dysfunction as they relate to physical therapy. Some other things that I do are treat women either during their pregnancy or after delivery, whether it be a vaginal delivery or a C-section. There's lots of room for physical therapy there. I also treat women with abdominal or pelvic pain, with vulvar pain, and today we'll talk a little bit about sexual pain as well. And then obviously, if you look at this cute little cartoon, which is like my favorite cartoon of all time, a woman exercising her pelvis, look at all those bones and imagine all of those muscles that are there that can cause, just different types of orthopedic dysfunction as well. And I would like to I'm going to pause for just a moment and acknowledge, I don't know if there are any men attending today or men in the audience, but if you are, thank you for being here. Even though this talk is going to really be geared towards women, all of the information that you get today is perhaps something that could help you understand symptoms of someone you know or someone that you love, and just help understand what they are going through. So let's dig in here. We'll start talking about incontinence. Like I said, this is another word for urine leakage or dribbling or wetting your pants. There are all different ways to describe this problem. And what you'll see there in the bold print is a statistic that 50% of young women who have never been pregnant will occasionally lose urine with coughing or sneezing. That's a big number. A lot of people are surprised by that number. And that number comes from, there was a study back in, I think it was 94, out of the University of Iowa, where they looked at and interviewed female elite collegiate athletes. And in talking with these women about the type of leakage that they may or may not have been experiencing during their sport, they discovered that a fair number of these women were leaking urine outside the context of their sport. And it helped introduce an idea of continence threshold, which means that even with the best circumstances, so being young, never being pregnant, in the best shape of your life, that even in that context, there might be times when your abdominal pressure is so great, like bronchitis or vomiting, when that pressure is so great that no matter what, it's going to be hard to stay dry. And I think that's something that is reassuring. It helps us understand this problem a little bit better. But I do want to point out that even when something is common, that does not mean that it is something that we are meant to live with or that we consider normal, especially if this is the kind of losing urine that's not just occasional, but is happening more and more frequently. So you'll also see listed here the different types of incontinence, or most common types of incontinence: urge incontinence, stress incontinence, and mixed incontinence. Mixed incontinence being when you have symptoms of both urge and stress incontinence. So we're going to get into those in just a little bit more detail. So let's talk first about stress incontinence. Stress incontinence is a truly mechanical problem. The mechanism relates entirely to support of the bladder and the urethra being the tube that the urine comes out of. So what happens is, I'm going to start talking with my hands here, and you're not going to be able to see it on the camera. So imagine me just really being demonstrative right now. So your pelvic floor muscles are meant to contract. When they contract, they squeeze together and they lift up. And what they're lifting is the urethra, that tube that the urine comes out of. They're lifting that urethra up towards the pubic bone and sort of pinching it closed, providing closure so that urine does not escape. So you can imagine that if you have muscles that are weak or inefficient, very stretched out or long, then it would be really difficult to get that urethral closure by lifting those muscles all the way up. And we need that lift anytime there's a pressure down. So if you cough, there is abdominal pressure downward, and that is meant to be met with a lift upward. When those things don't happen, that produces leakage of urine. Urge incontinence, on the other hand, is any type of urine leakage that happens in the presence of or right after a really strong sense of urgency. So when you see commercials on television for medications where they're singing, gotta go, gotta go, gotta go right now, that they're talking about urgency and urge incontinence. This tends to be a little bit more complicated. It's not just a simple mechanical problem, and it can be really strongly impacted by outside factors, such as fluid intake or what we call bladder irritants. So I'm going to tell you a story. This is a time when urge incontinence was not more complicated. It was actually really easy to figure out and solve. I had a patient years and years and years ago who was having what she described as a very strong urge to go to the bathroom, and she just could not make it to the bathroom. She would wet her pants on the way to the bathroom. And when we talked about what her fluid intake was like, she told me that she was drinking 4 pots of coffee a day. And I said, "Oh, you must mean 4 cups of coffee." And she said, "No, I mean 4 pots of coffee." And so you can imagine this wasn't complicated. This was easy. We had to make some changes to her fluid intake and how much coffee she was drinking. That coffee was really irritating the lining of her bladder and causing leakage. So other factors that can impact urgency would be estrogen status. So if you are postmenopausal, it is possible that having less estrogen can create more urgency. And then constipation. There's only so much room in your pelvis, and if a lot of that room is occupied with stool, it can cause problems for your bladder. So this is something that is perhaps just a bit more complicated than stress incontinence. And both are very easily treated with physical therapy. Before we get to what that treatment might include, I want to just talk about prolapse. So prolapse is essentially the bulging downward of the walls of the vagina. It is very common, and having prolapse is not necessarily pathologic. Okay, so and I think that's important to understand. Hopefully on your screen, this looks awfully small on my screen, but hopefully you can see these images here. If you look at the image on the far left that says normal anatomy, what you're looking at is a woman's pelvis from the side. Okay, so in the front is the pubic bone, and then you'll see the bladder right behind that, and then behind that, the uterus, cervix, and vagina, and then behind that, the rectum and anal opening. Okay, so if you were to look at the next picture over, a cystocele, that's a fancy word for saying a bladder prolapse. What that might look like is that the vaginal walls are not well supported any longer, allowing the bladder to sort of push down on that part of the vaginal wall. And that's something that a woman might feel. She might feel a bulge in the vagina, or like there's something coming out. Sometimes people describe that as a pressure, but very rarely is it something that is described as painful. Some women might experience difficulty emptying their bladder or their bowels, and if that becomes a big enough problem, that can be dangerous, and that's something that we would certainly want to intervene. Otherwise, like I said, this is not always symptomatic. There are plenty of people walking around with prolapse who don't even know it, no symptoms whatsoever. So the existence of a prolapse is not necessarily a problem. It is when someone has symptoms relating to a prolapse. So, you know what? Actually, I'm going to go back. And one more thing about prolapse, just to understand it a little bit better. Let me talk with you about what kinds of things might put you at risk for a prolapse. So certainly pregnancy and childbirth, but also things like repetitive straining. So chronic constipation or even chronic cough. Oh, this is another good story I'll share. When I think I was a student at the University of Iowa, they're always doing studies, and I signed up for one because I think I got $20 or something like that. And it was a study that looked at what kinds of things created a lot of forces downward on your pelvic floor. And they were measuring the forces on my pelvic floor, and they had me doing things like lifting things from the ground and lifting overhead and jumping. And at the time, I was having it was allergy season, and I was having an exacerbation of my asthma. And when I would cough is when they saw the biggest impact on my pelvic floor was that coughing. And so I always think of that when I talk to women who have COPD or some kind of chronic cough, that's something that can really impact your pelvic floor and the stresses that go through that. Another thing that can contribute would be a lot of heavy lifting, and then certainly just the genetic component. Some people have really stiff connective tissue, and other people have connective tissue that's a little bit looser that would make them a little bit more vulnerable for symptoms relating to a prolapse. Okay, so we've talked about urine leakage and we've talked about prolapse. I would like to get to now what do we do about those things? And I'll start by just talking about how effective non-pharmacologic, non-surgical interventions can be for these types of problems. So I'll give you an example. Someone with urge incontinence, if they presented with that complaint to their doctor, one of the things that might happen is they might be prescribed a medication for their incontinence. But there's nothing wrong with that. Those work pretty well. When we compare the effectiveness of those medications to behavioral changes, things we might do in physical therapy, there's definitely more room for improvement with those behavioral changes than with drug therapy. And for that reason, behavioral changes are the first line therapy for urge incontinence. So if someone were taking medication, we would need 9 to 12 patients to be treated in order to get one who reports improvement. With physical therapy or behavioral changes, we only need 3 patients to be treated like that for one person to report improvement. So oftentimes that's why medical providers say, well, let's try physical therapy first and see how much that can give you before we move on to the next tier. So when I'm trying to help someone determine how they should exercise their pelvic floor, I'm considering things like the intensity and the duration of their exercises. What position are they in? How hard are they squeezing? How long are they holding the squeeze? How many are they doing? It's a lot more than what I hear from a lot of women is, oh yeah, I just squeeze those muscles when I'm at a stoplight. I read that in a magazine. And, when we think about these muscles like we would any other muscle in your body that you were trying to build strength in, that's not how we do it. We don't tell people who are trying to build leg strength, oh, hey, just whenever you think about it throughout the day, just do a squat. That's not how we build muscle. So the exercise prescription is really important. Other things that we might talk about would be fluid management. How much water are you drinking and when are you drinking it? a large number of women are really limiting their fluid intake because they're afraid they're going to leak. And the more dehydrated you become, the more concentrated your urine is, and the more likely you are to have irritation of the bladder lining and a leak. I have other women that I talk to who are really busy during the day and say, oh, I know I'm supposed to drink water. I'm trying to drink more water, but I end up having to drink it all at once because the rest of the day I'm just so busy. And then they might have a leak after drinking, 48 ounces of water straight or something like that. And then certainly avoiding things that can irritate the bladder lining, like we talked about earlier, 4 pots of coffee, that'll do it. Other things that irritate the bladder lining would be other things that have high acidity, like citrus, orange juice, grapefruit, lemons, that kind of thing. Caffeine and carbonation. Sometimes just carbonated beverages can be really irritating to the bladder. We also talk about scheduled voiding, which basically means getting yourself on an interval, making sure that you're emptying your bladder often enough. So teachers and nurses generally have a really hard time with this. They've maybe spent decades of their life not having an opportunity to go to the bathroom, having to hold their urine for 3, 4, 5 hours at a time. And that's not healthy for your body. If your bladder's very, very full and you sneeze or cough, it's a lot more likely that there will be a leak than if you have just emptied your bladder. So someone who's well hydrated is probably emptying their bladder about every 2 hours during the daytime. We also talk about constipation management because we know that that's something that can contribute to urgency and urge incontinence. A lot of patients ask me questions about weight loss, and it is true in particular for stress incontinence that actually even a small amount of weight loss, I think it's 5% of your body weight, can have an impact on symptom. And that's because if we go back and think about what causes stress incontinence, the mechanics of that, the more pressure you have in your abdomen, the harder it's going to be for your pelvic floor muscles to get that urethra lifted up and closed. And then the last on my list is something I don't do. Your physician can help with this, but fitting with a pessary. Pessaries are something that women use to manage both stress incontinence and prolapse. And it's essentially a device that gets inserted into the vagina. It can be taken in and out, and it helps to provide support. I think of it like a orthotic for the vagina. These things are very effective in managing symptoms relating to incontinence and prolapse. Okay, so we'll shift gears a little bit and start talking about bowel function. And I think the most common question I get from people is, what's normal? Like, how often is somebody supposed to be having a bowel movement? And that's a really hard question to answer, actually. I don't know that we have an agreed upon normal because everybody's a little different. Most women are having a bowel movement at least every other day. And if we look at the definition, the medical definition of constipation, that implies that anyone who has less than 3 bowel movements a week and or has to strain a lot to empty and or has very hard stools for a sustained period of time, that would be called constipation. So if you look at this Bristol stool scale over here, this is something that I use frequently with patients to help understand the consistency of their stool. If someone tells me, yes, my stools look like a type 1, that helps me to understand that these stools are really, really hard, difficult to pass stools. So some examples of bowel dysfunction. Let's talk about constipation first. Everyone has experienced some level of constipation in their lifetime, but about 1 in 3 women are experiencing chronic constipation. And the things that contribute to chronic constipation are things like the medicines that we take. Lots of medications have a side effect of constipation. And sometimes there's just another medical problem that can lead to constipation. Things I think about are thyroid problems, Parkinson's, MS, even really advanced diabetes. Those are all things that can contribute to constipation. And for most of us, there's a little bit of a behavioral component, what we put in our mouths, how much water we drink, and whether or not we're moving our bodies. These are all things that our bowels need in order to function properly. And then last but not least, pelvic floor muscle function and coordination. So about 50% of women with chronic constipation have a problem coordinating their pelvic floor muscles to allow for full emptying. We're going to talk about that a little bit more when we get to the treatment section, but that's really important. One more story just to keep things lively. When we're talking about diet, a lot of people want to know, oh, what's the best diet for me? And the answer is whatever diet is best for you is the best diet for you. It's much easier to determine what's not the best diet for you. So I had a patient probably 10 years ago now who was having a lot of trouble with constipation and wasn't taking any medicine, no medical problems. Her pelvic floor seemed perfectly fine. And so I had her fill out a little diary for me where we looked at what she ate and what she drank in case maybe that was part of the problem. And this woman brought back a diary. For 3 days, the only foods that she consumed were chocolate Pop-Tarts, butter. I think she put the butter on the Pop-Tart, and Skittles. That was it for 3 days. And that it just hadn't occurred to her. This is how she always eats. It had not occurred to her that that is something that could be problematic for how her bowels function. And making some simple changes for her made a big difference. That's an extreme example, but I can't stop thinking about the butter on the Pop-Tarts. Okay, so another problem, we've got the problem of constipation where you can't go and you want to. And then we have the opposite problem of fecal incontinence when you're going and you don't want to. And this affects about 1 in 12 people with multiple contributors again. So going back to that Bristol stool scale, stool consistency is really important here. If you have really watery, loose stool, it's going to be much harder to hold that in. Lots of medical problems can contribute, especially GI problems like Crohn's disease or colitis. Even things like really significant obstetric trauma, radiation therapy can have an impact on how your bowels function. Diet again, and then in a really confusing twist, constipation can be the actual cause for people who are experiencing leakage of stool. So sometimes when we get backed up enough, the only parts that can come out are the loose stool that kind of sneak around the sides and come out. And so especially for people who tell me, well, I didn't really have like an urge to go, my stomach didn't grumble, I keep having these really small accidents, or I'll go to the bathroom and realize there was something in my underwear and I didn't know, and it's really loose. Sometimes constipation is actually to blame. So let's talk about the treatment. Let's talk first about fecal incontinence. So the most important part of managing fecal incontinence is figuring out, is it truly fecal incontinence with an urge, meaning it can't hold the stool in, or is it really constipation? It's really important to be able to determine that cause if we're going to find the right path forward. when someone has really loose stool and they're leaking a lot, sometimes something as simple as increasing the fiber in their diet, whether it be actually dietary fiber or with a supplement like Metamucil or Benefiber, bulking up the stool and making it more solid can take care of the problem. Sometimes these are things that require help with medication, whether it be constipation or fecal incontinence. And then I wanted to spend time talking about what we would do if the problem related to your pelvic floor muscles not being able to coordinate well enough to allow the stool to come out. So this is a really specific type of constipation with a fancy name called dysynergia or dysynergic defecation. And what it means is that, normally someone's normal defecation pattern should look like an increase in abdominal pressure, a little small push. And when that's happening, the pelvic floor muscles and sphincter muscles should be lengthening, opening, relaxing in order to let the stool out. And what happens when people have problems with these muscles coordinating well is that either they're pushing, but instead of those muscles relaxing, they're actually squeezing, or they just don't relax enough. And that's something that's sometimes really obvious just with a physical exam. We can see that or feel that that's happening. And sometimes it requires more sophisticated testing to be able to determine that that's the problem. So the image that you can see on your screen is a really expensive probe with little pressure sensors on it, and sometimes a balloon. But the pressure sensors measure what's happening in the rectum. How much is this person able to push and create downward pressure? And then the large group of sensors are measuring how much pressure is there in the pelvic floor muscles and the sphincter muscles. So if there's a big increase with a push in that rectal sensor, and at the same time, there's a big increase in pressure from a squeeze of your pelvic floor muscles, you can imagine it would be really hard to get something out. You would need to push and push and push and feel like you have to go and not be able to get it out. And so we use this type of sensor to help diagnose that, but also to help treat it, to give people practice in coordinating the right type of pattern. This is equipment that is in the GI lab that I utilize. Another thing I thought I would include is a squatty potty, just because some people watch Shark Tank and they've heard of that. So the basis for the squatty potty is that when someone sits down with their knees above their hips, so in a simulated squat position, that it changes the angle of your pelvic floor muscles around the anal canal, opening the anal canal and making it easier for someone to go, even if they have really tight muscles. So the squatty potty is basically like a little footstool that you could use underneath your toilet to prop your feet up on, so that it's like you're squatting. Okay, so let's shift again. This is our last topic. We're going to talk about sexual pain. And I'm going to read this first sentence twice. Up to 75% of women will experience pain during sex at some point in their lives. 75% of women will experience pain during sex. That is a very large number. And there is no problem more complicated in my mind than this. When you think about the impact that this kind of pain can have on a relationship, on a person's self-esteem and sense of value, and you factor in the really high rate of sexual abuse experience, sexual assault, trauma, this becomes a really complicated problem. So the most common contributors to this type of pain are dermatologic, so vulvar health. If something is painful right on the outside of the vagina, it's likely to cause pain with penetration. Hormone changes, specifically postmenopausal women with less estrogen may experience dryness or pain. Muscle tension and stiffness can be very painful. People with bowel and bladder problems, for example, someone with, let's say, a lot of fecal urgency, so maybe colitis or something like that, where they are spending a good part of their day with those muscles clenched to try to prevent a leak, that can be problematic over time and cause problems. Sometimes just really difficult relationship dynamics can contribute to a bad experience, and certainly trauma history. Actually, one other thing I'll highlight relating to muscle tension and stiffness is just the range of orthopedic issues that can make sex difficult or painful. Low back pain, total hip replacements, it changes how your body moves. And this is something that with such an enormous incident, 75% of women, I wish we did a better job as providers about asking and bringing it up, because this is a hard thing to talk about with your provider. But I want everyone listening to know that it is okay to ask about your sexual health. And if you don't get an answer that you feel good about, it's okay to ask someone else. So what do we do for the treatment of sexual pain? This is one of my favorite quotes. For every complex problem, there is an answer that is clear and simple and wrong. I like to say that complicated problems require complicated solutions. So when you've got multiple factors contributing to an experience, it is best to really make sure all of those components are being addressed. And my bias is I really feel like women are treated for this type of problem best when there is a team involved. So if someone's experiencing bladder or bowel symptoms that might be contributing, there should be someone who's helping them with that. If they have a gynecologic problem contributing, they should have a gynecologist. If they are struggling to cope with relationship issues or how this makes them feel or how to manage this, there should be a brain health person, a mental health provider. And then there's an enormous role for physical therapy to help coordinate all of these efforts and address the muscle dysfunction. So I'm gonna end the talk a little bit early so that we have plenty of time for questions or even discussion. If you would like to type a question in the chat, I am happy to read it aloud and answer the question to the best of my ability. I'll give you a moment to think of some doozies.
And what I can do, I'll work on wrapping our program up, but know that if a question does come up, that we will go ahead and we'll have Katie jump back in and she can answer those questions. So thank you, Katie. Wonderful presentation, and she does look like a model, by the way, today. So no, lots of wonderful information. Sometimes a topic that can be hard to discuss. So I so appreciate her willingness to come in today, and she does a fabulous job here. So thank you so much. I want to remind everybody we have a program tomorrow. Again, Dr. Vandenberg is doing a program on aging skin, keeping it healthy and wound-free. And by the end of July, I'm hoping to get to you August through October's programs. I can give you a little insight here. Right now for August, we have a program on August 17th, resistance, exercise, and mental health. And then Tuesday, August 30, 30th, we're doing a program on dementia conversations, kind of having those difficult talks with somebody that you think may be having some memory issues, potentially Alzheimer's and others. So a couple great programs coming up for you in August. You cannot sign up for those yet, but in the next couple of weeks, I will have more information out to you. So, well, I am not seeing any questions. If anybody ends up having a question and you didn't want to ask it today, you can go ahead and shoot it to me and I will go ahead and share with Katie. And as you can see, she has also put her email address up there also. But if you don't have your hands on that, again, go ahead and shoot it to me and I'm happy to share it with Katie. So thank you, Katie, very much. Great presentation. Thank you for joining us, everyone, and hopefully you'll join us again tomorrow. Have a great day.